Today we are going to discuss a topic which is very important for pharmacoepidemiology and pharmacoeconomic, evidence synthesis. We will begin by discussing why do we need evidence synthesis, defining it, and also the type of questions that the policy makers and also the managers want an answer to. And then we move on to a specific types of evidence synthesis, which is systematic review. We discuss why systematic reviews are the best way to answer the questions that the policy makers and managers are asking. And we will move on as well to go into a bit more details on how the approach of systematic reviews and move on to also a bit more advanced reviews, which is a meta-analysis of effectiveness. So, how are evidence generated? So, usually, evidence are generated through primary study, either through observational study, where you observe without doing any interventions, or you do an experimental study, where you actually do an intervention and try to compare and try to see whether there is any effect or any changes in the population that you are observing. And then you report it, and then those reports are actually evidence of the study. Okay. So the practice of evidence-based medicine, or EBM, which perhaps many of you have heard from your reading in the literature, are actually the practice that integrate individual clinical practice with the best available external clinical evidence from systematic research and patients' value and expectations. So usually, before the age of EBM, clinicians just do according to what they're being taught in the medical schools. So, but imagine after you have graduated from medical schools after so many years, so if you are still doing the same thing that which is being taught to you 20 or 30 years ago, so your medical practice might not advance. So what happened with ABM is that we know that the clinicians actually, when they are practicing, they're supposed to also looking into the body of literature as well to find out what is the best way to actually treat the conditions. So the age of EBM, or evidence-based medicine, is actually proposing that the practice should be based on a combination of all these three. That it should be based on the individual clinical practice, the best available external clinical evidence, and also the patient's value and expectations. So the reason why we need to synthesize evidence is because evidence is the one that is driving the clinical practice and also public health decision making. So usually, when you are looking into something, I mean, for example, you are looking even to shop for a handphone or computer, you might be looking for a review. You might be looking for feedback from other customer. So maybe you're looking for LoyakNet forums. What did they say about this smartphone, or what they say about this model of computer, what they're experienced with, or you might want to go to drop into one of your YouTubers trying to see how actually they are experienced when they're using it. So the same thing comes with clinical practice. So when clinicians trying to solve a clinical diagnosis, so they look into the evidence in the body of literatures. So in order to do that, you need to know how to actually look into the right directions and how to actually make sense of the information. And in the age of Donald Trump, so we know that fake news can actually lead to a misleading clinical practice and also public health decision making. So this evidence that inform clinical practice and public health decision making, it actually comes from a good review of state-of-the-art synthesis of current evidence on a given research questions. Given that there is a lot of medical literatures out there, and the fact that time is always scarce, review articles play a big role in decision making. So you cannot have that for every single diagnosis that you made in your clinical practice, that you go into the literatures, try to find clinical trials, try to find the observational study to inform that decisions, because there's a lot of articles being published every year. In fact, if you want to keep up to date with internal medicine, you need to read 17 articles a day, 365 days a year, and that's a lot. Given that most clinicians and pharmacists do not have time to track down all the original articles, critically read them, trying to know whether this is fake or is it true, or is it genuine articles, and also obtain the evidence that they need for their questions. So systematic reviews and clinical practice guidelines may be their best source of evidence. So this systematic review or clinical practice guideline, or CPG, which you might have heard of, is actually a pre-digested source of evidence. So there are articles that combine the information from all this primary evidence and just make a summary of them. So this is actually what evidence synthesis is. So the EBM movement is heavily dependent on these pre-appraised evidence sources. So Carl Pearson is probably the first medical researcher to use formal technique to combine data from different studies, and this is way back in 1904. He synthesized data from several studies on efficacy of typhoid vaccination. So his rationale for putting data is that many of the groups are far too small to allow of any definite opinion being formed at all, having regard to the size of the probable error involved. So what he's been saying is that many of the studies are perhaps quite small in their sample size, and maybe they are quite localized as well. So it might be difficult for people to actually summarize all this body of evidence. So what happened to him is that he was saying that, how about we combine all of these studies and make a conclusion out of it? So this is what actually being proposed by R.T. Cochrane, British research, which actually where the Cochrane collaborations come from. In 1979, he wrote, "It is surely a great criticism of our profession that we have not organized a critical summary by specialty or subspecialty adapted periodically of all relevant randomized control trial." So these collaborations, the Cochrane collaboration, is one of the most renowned evidence synthesis movement in the world. So his challenge led to this collaboration establishment in the 1980s, where they have finally, from the first collaboration that they did with the Oxford database of perinatal trials, so the other researchers actually found the Cochrane collaborations in 1993. So we can found, if you are interested more into this evidence synthesis, you can just browse through this Cochrane collaboration and look into the vast synthesis, body of synthesis that they actually have there, that they have a report on various study questions. So before we move on to evidence synthesis, so by now, I hope that you understand. So evidence synthesis is simply the process of making sure that we can make sense of all the evidence out there. So, and in order to do that, there are many ways to do it. Okay, so one is what we call as a review, the process of bringing together a body of evidence from different sources. So this is just the general definition. Okay? Synthesis is a stage of a review in which evidence extracted from different sources is juxtaposed to identify patterns and directions in the findings, or integrated to produce an overarching new explanation or theory which attempts to account for the range of findings. So those two, review and synthesis, are the general definition which you might find that define what is evidence synthesis. So within this evidence synthesis, there are various tools, various different type of review. So one is traditional narrative review. Second, a higher level systematic review. You go on to overview, meta-analysis, and pool analysis. So here is a diagram which shows relationship between all these type of reviews. So all reviews is what we also call as overview. And this is the big set of review all in the universe of reviews of evidence synthesis. A subset of these reviews is called systematic review. Subset of them are meta-analysis, and the subset of meta-analysis is what we call as individual patient data meta-analysis. Okay, so what are they? Traditional narrative review are usually written by experts in the field, are qualitative narrative summaries of evidence on a given topic. Typically, they involve informal and subjective methods to collect and interpret information. A systematic review is a review in which there is a comprehensive search for relevant studies on a specific topic, and those identified are then appraised and synthesized according to predetermined and explicit methods. Meta-analysis is the statistical combination of at least two studies to produce a single estimate of the effect of the healthcare intervention under consideration, whereas individual patient data meta-analysis involve obtaining raw data on all patients from each of the trials directly and then reanalyzing them. Okay, so these are the definitions of the tools that we have in evidence synthesis. So in summary, what we have, if you are doing a traditional narrative review, usually, for example, let's say that you are looking for the effectiveness of paracetamol to relieve fever in children. So maybe what you should do is, in the traditional review, is that you take someone, maybe a pediatrician. Okay, so you ask a pediatrician, a specialist in the field, can you write something about the effectiveness of paracetamol to treat fever for children? So this pediatrician then will go down to his library at home, perhaps, dig out a little bit, and then based on his clinical experience, and then he wrote 10 or 5 pages of articles describing the effect of paracetamol to treat fever. So this is what a typical traditional narrative review is, usually by the experts. But as you can imagine, these have certain disadvantage. Number one, it can be subjective, prone to bias and error. So it based on the clinicians or the experts' view. Some clinicians, they might not feel that treating patients with paracetamol is the best way. So they say that, okay, then they will be biased to say that paracetamol, they will try to make sure that the evidence, the way that it's written, to say that paracetamol is not the best way. And the literature search that may be done by the experts might be patchy and inadequate. They might be looking into what they have in their own library. And as you know, if you have clinicians or maybe experts in USM, for example, trying to do a traditional review, so the USM library itself does not subscribe to many journals. So it means that there are perhaps evidence out there which is not being covered in the traditional review. Selective citations of literatures. So it may be because the patients, the reviewer, the expert do not have access to that literature, or do not like the authors, or do not like the way that it was written, so they just exclude it. There is no descriptions of the methods used by the review. So sometimes if you're doing a traditional review, you just say that you do not describe how you look into the, how you find your literatures and how you actually analyze them. Usually you use vote counting as well in traditional review. For example, like if you are looking for study for fever, for example, so maybe you found there are 10 studies that examine the effect of paracetamol in reducing fever among children. But maybe what you found is that 9 studies says that there is no effect. But one study says that there is an effect that the paracetamol actually can be effective in reducing fever among children. So what happened with vote counting? You just count how many studies that say yes and how many studies that say no. But this can be misleading. What if these 9 studies that say no is actually bad studies? They only done it in perhaps 1 or 2 patients, and they were done very haphazard. There is no random control. Whereas the one study that say otherwise were actually a very good, with a good sample, large sample size, well-controlled study. So if you're using vote counting, it can be misleading. Usually not quantitative. So traditional review, they're usually not quantitative. It means that they just try to summarize in terms of without trying to looking into the statistical analysis or trying to reanalyze the results from the study. Readers can judge the quality of the review because because the methods were not well described. So usually, in order for the readers to know whether a paper is good or not, so let's say that you are looking into a primary study, a randomized control trial. So in order for you to know whether that randomized control study is a good study, you look into whether the sample size is enough. How do they do the selection, for example? So maybe if you know that they actually select among their close family members, then you know that there is a selection bias there. And a good clinical trial study should also describe how did they give the intervention. Is it randomly or is it conveniently? Because knowing that, then you know that maybe there is an allocation bias which can lead into the lower quality of the study. So in traditional review, the reviewer do not describe how did they actually do the review. Whereas in systematic review, for example, they will describe in details where did they get, how did they search for evidence, what did they do, what do they do to this evidence, how do they conclude from this evidence. Okay. So without that information, readers will know how actually the reviewer in the traditional review made a connection between what he read with what he wrote. And because of this absence or lack of information in the methods that being used by the reviewer, the readers might not be able to also replicate or verify the review. For example, in traditional review, you do not describe how did you search for your evidence. Okay? Whereas in systematic review, you describe specifically that you search in Google, for example, using the keyword paracetamol and children. So if the readers want to try to replicate such a review in a systematic review, what they do is that they try to do the same thing like this reviewer, and they, by right, they should be able to replicate the same thing what the reviewer have done. And this is not possible in a traditional review. It's also hard to separate research evidence from anecdotal experience. Because in traditional review, it was written in a way that sometimes the researcher or the reviewer usually take much from his own experience and blend it together with the evidence and wrote it as a masterpiece. So sometimes it's quite difficult for us to actually to see whether is this the personal opinion for the reviewer or is it the from the evidence. So narrative reviewers may also disagree with each other. So some reviewer might say other thing, some reviewer might say a different thing. And because the way that they do the review is not in a systematic way as such in a systematic review usually do. Okay, so how does a systematic reviews better? You don't have to be an expert to do one. So whereas in traditional review, you have to be an expert or so-called the key opinion leader in order to make an opinion on that. But a systematic review, even undergraduate students like you can do. Okay, in fact, many of you here are doing a project on systematic review for this semester. So systematic review as well are more objective, less prone to bias and error, because you explicitly outline how you're going to do it and you follow it through, like what usually scientific research usually are. So literature search is also more comprehensive, exhaustive, and repeatable. There are also clear descriptions of the methods being used. You also, because when you try to clearly describe your methods, you also describe how you actually choose the evidence, the studies, the published studies, in order to be included in your review. So there are explicit criteria how you choose your study. And you also have to include assessment and discussion of quality of primary studies. And this actually can help the reviewer to know whether your review filter out good study and bad study. Okay? So quantitative synthesis in a systematic review avoid vote counting, which is usually what happens in traditional review. And because in meta-analysis, you pull the data from all across different studies, you can actually pick up the small effect, which you might not be able to do it in a traditional review. So because the methods are explicit in a systematic review, readers can actually also replicate and verify the review. So we now move on into how we actually conduct systematic review. So as you see here in this quite a confusing and complicated diagram here, systematic review is a step-by-step process. Okay? You start from the top where you define the questions, what you're trying to ask, what you're trying to answer, and then you move on into designing that review process, identifying your studies, identifying the sources, searching for it, making sense reading it. So you see in the middle of the diagram here, there is a reviewer 1 who screen all titles and abstract and make selection for a second screen, and there is another reviewer which also do the same thing as well, read the same thing, and then they actually have to try to resolve this disagreement if they do have it, okay, and then make a conclusion out of it, and finally, once you analyze it, then you actually report it. So usually what we have, this is the usual main activities that you have to do when you do a systematic review. And this is important especially for those of you who are doing a systematic review now, to actually make sure that you plan the 10 members, 10 or 13 members in your group to actually play a part in some of these activities. So you have to make sure that you distributed the task well, and so that then you make sure that you can actually complete it in time for your submissions in May. So the review begins by preparing your protocol. So you have to plan ahead. So protocol is like your research proposal. But in terms of a review, you are actually writing a proposal of how you're actually going to do the review to answer the questions. And then you move on to actually execute the review by first searching for published and unpublished studies. So you then move on to pilot testing your eligibility criteria, inclusion assessments, pilot test, again, your risk of bias assessment. Then you look into the validity assessment, you collect the data, enter the data, analyze it, and prepare the reports. Okay? So we move on to the main elements of the systematic review, so that then you can understand better this process. So as you can see, in a systematic review, there are 6 main elements. First, you have to formulate the review questions and write a protocol. Second, you search for and include primary studies. You assess the study quality. You extract the data. You analyze them, and then you interpret it. Okay. When you formulate the review questions and protocol, it's the same thing, similar to when you have to ask your research questions. Okay. So when you ask the questions for a systematic review, there are a scientific way for you to ask these questions. For example, let's look at these 2 questions here. How are these questions different? The first questions, are condom effective in preventing HIV? The second questions, in men who have sex with men, does condom use reduce the risk of HIV transmissions? Now, as you can see there, the second questions is more complete, it's more specific. And this is what we want with a questions. That a focus questions, they need to have at least 4 parts. PICO. P, who is the patient or what problem is being addressed. I, what is the intervention or exposure. C, what is the comparison group. O, what is the outcome or endpoint. And perhaps if you want to add another one, you can also include study design, whether you want to include all study design or you just want to focus on control trials only. So when you describe a patient, it can be the disease, the condition, the stage, the severity, or the demographic characteristic, or combination of them. Intervention, you should actually describe specifically what type of intervention or exposure that you're looking at. And whether it is going to be parenteral administration or is it oral administration, any dose, or is it just a specific high dose. You should also describe the comparison. Is it a placebo or alternative therapies? And you also need to also describe in the questions the outcome that you're looking at. Whether it is going to be risk reduction or is it going to be for prevention? Is it going to be the outcome should be in dichotomous, die, dead or alive? Or is it continuous? The rate of the blood pressure, or maybe the temperature, or any continuous outcome that you can imagine. And also you can also describe the type of outcomes there, mortality, morbidity, quality of life, and so on and so on. So here is examples of how we can actually formulate a proper therapy questions. So you can see the top one is zinc effective in treating cold. So you have there zinc as the intervention, cold as the outcome. But as you can see there, there's only 2 elements of PICO there, which is I and O. And this is not complete. So in order to make sure that we can formulate the PICO questions for this case, so maybe what we can do is we have to make sure that we describe who are the patients that we are targeting, and also perhaps what we are comparing the intervention with. So we can reformulate the questions as in children with common cold, is oral zinc effective in reducing the duration of symptoms as compared to placebo? And as you can see here, we have the patients, children with common cold, intervention, which is not only we are saying that it's zinc, but we're also describing that it has to be administered orally. We describe the outcome as duration of symptoms, and we also have the comparison as a placebo there. So we can also add in the study design there as that we are only looking at RCT. So a focused study questions would help us to search for studies more specifically and more targeting to make sure that we can actually effectively answer our questions. So if you have, because what happened with this PICO is that we are actually trying to make sure that we define where is the overlapping area that we are interested in. So if you have the first set as a portion of problem that we are describing, the second set as intervention and comparison, and the third set is outcome. So we are looking at the overlapping area for the three sets there that will actually help us to make sure that our study, our search will return a more specific and focused evidence targeting our questions. So once you define your review questions, so the next step that you need to do is to actually try to search the literature and see if any review has already been published. And this is what we call as scoping search. So you look at sources like the Cochrane Library or the DARE database, or maybe just Google. And you can also perhaps use filters in PubMed to identify systematic reviews. So if any review has already been done, you do not need to reinvent the wheel. If the review is recent and complete. But if the review maybe was outdated, maybe it was like 20 years ago or even 10 years ago, and maybe it was only a traditional review, not a systematic review, so maybe then you have a case to actually make another review. But if there is already existing high quality systematic review there, so maybe you need to actually consider an alternative questions, because that questions has already been answered. So this is examples of the Cochrane Library interface that you can see here. So this was done long time ago, and as you can see, it was using Netscape browser, which I don't think it exists anymore nowadays. And here we have a PubMed, looking at also a systematic review filter. So once you decide to do a review, so next you have to do is actually write a short draft protocol. And those of you there who actually are doing systematic review of your group project, so your field supervisor has actually helped you out with part of this protocol. But you do actually need to make sure that this protocol are being revised to make sure that it can accommodate what systematic review are expected to do. So in this usually 2 pages protocol, okay, so what you need to do is actually to have a background, your 4-part questions, and study designs, and also methods. So this protocol actually force you to read and understand the background so that you know actually what you've been asked to do. Okay. For example, some of you perhaps are doing on the course of trying to do a review on course of thalassemia treatment for major beta thalassemia. So perhaps then, when you are doing this background, you also have to know what is actually major beta thalassemia. Is there an alpha or gamma thalassemia? Is there a minor and other part of thalassemia? So doing this protocol also make sure that you actually formulate a more focused questions, plan your search strategy, okay? Make sure that force you to actually describe your inclusion and exclusion criteria, and also make you think about the data that you want to collect and the methods that you will use to analyze them. So once you do this, once you make sure that you already done this protocol, okay, where you're going to search for it, how you're going to search for it, what you have to do is actually do a quick and dirty initial search of the literatures. Simply put a keyword search with a PubMed, okay? So maybe select, obtain 2 or 3 studies. So pretend that these are the studies, these are the body of the literatures that you have to analyze. So what you need to do is that with these 2 or 3 studies, you extract them using the data extraction forms that you have, and then try to analyze and conclude from it. Okay. So with this pilot experience, by right, you should be able to see whether the forms that you created is sufficient or not to abstract all the information that you need from the study. And also perhaps you will also know some of the key terms that being commonly used in the literatures for the questions that you are asking. Okay, so with this pilot study experience, you actually revise the protocol, and then you can actually start the review to make sure that you can have a proper and full systematic review. So a full protocol in a Cochrane protocol is actually a bit comprehensive. So you have to have all this background, objective, the criteria for considering studies for the review. Okay, we will actually try to describe a little bit, a bit more details on this each element of the protocol. In the background for a protocol, you need to have a problem statement. The importance of the problem be addressed. Why do we need to know the cause of thalassemia? Why do we need to do a review on the cause of major beta thalassemia? Is it because that there are mixed evidence there? Is it because we do not know what is the cause of thalassemia in Malaysia, and we want to know, is there any evidence from our neighboring countries about the problem? Okay. We also have to describe the conditions. Again, in the case of thalassemia, what is major beta thalassemia? What is transfusion-dependent thalassemia? You have to describe the intervention as well. So if you are looking for a treatment for beta thalassemia, for example, so what are the interventions that being used to actually treat patients with beta thalassemia? How do they actually work? Was it by a certain biochemical pathway, or is it not fully understood? So you have to make sure that there is a rationale why you have to do the study in the first place. It cannot be just because your supervisor or your teacher asks you to do that. You have to make sure that the reason why you do this review based on the body of literatures, the background that you actually outlined initially. Okay? So have there been other reviews on this topic? So you should actually do some reading on this. Make sure that you cover all this review. And is that review sufficient? And why is it not sufficient? Why you have to do another review if there is already existing review on this? And then you move on to your objective. You have to have a precise statement of the primary objective of the review, including the interventions review and the problem addressed. If there are hypotheses for the review, this should be stated here. So by right, you should have a clear objective in using verb to as an initial sentence in your objective. For example, to assess the effect of intervention or comparison for health problem then you have to specify what are the type of people, disease problem and setting. So by right, if you already done your PICO study questions, this should be easy, piece of cake. And then you should have the criteria for considering studies for this review. You have to identify what are the types of participants that you're looking at, the type of interventions, the type of outcome measure, okay, and the type of studies designs that you are looking at. The search strategy, what database and sources will be searched? Are you looking? So by right, you should try to make sure that you look into as much data source and source possible. Okay, so when we talk about the sources, it can be many. You can actually get the evidence from many sources. So if you only look into your USM library, it clearly shows that you lack initiative. Okay. And as what we discussed, what happens in the traditional review, people who actually limit their review to only what they can access in their own free time at their own convenience can either be called lazy or can also be called biased. Okay? Because it means that you already have selection bias of what you should be including. What we actually should be doing in systematic review is that we try to reduce this bias as low as possible. Make sure that our search are comprehensive enough so that then we can make sense of the evidence out there on the study questions that we are asking. So there can be many sources that you can get this evidence. It can be from database, which is where you can get, for example, the PubMed, the Medline, the the DARE, the Cochrane. You can also contact the researcher. So if you know, for example, certain researchers who are experts in the field, so you can write to them as well. Say that if you have any published evidence on this, if you've done on this recent study on this, can you please send us the reports so that then we can actually include in our review. It can also be conference proceedings. So some conference, you actually, especially for Malaysian conference, they actually do not widely distribute except in proceeding, which you can only get it if you attend the conference. So what you have to do is actually try to get this proceeding from the organizer or people who attended it, and then you can actually try to make sure that you include this evidence as well. You can also have it from the reference list. For example, you get an article, one article, and then at the end of that article, there is a section called reference. So you can actually get the other studies from this reference list, because usually a research, when they publish, they would also cite other research relevant to the field. And one of the sources that we usually include as well are pharmaceutical industries. So sometimes they have clinical trials which they do not publish. We can write to them and try to ask this information. Okay, and another source which are severely underestimated when we are doing systematic review, but sometimes very critical, especially when you are doing a policy analysis. So some of you here perhaps are doing a comparison between a centralization and decentralizations. So a lot of the evidence out there on centralization and decentralizations might not be published in a common journal articles, but instead they might be published in a government report or institution report, which is where what we call it from the grey literatures. Okay? So you have to actually dig out from somewhere else, go into the government agencies, and try to find out from their reports if there is such reports being published on the subject. So the ability to actually use multiple sources as your source of evidence would actually make sure that your systematic review at the end is a quality systematic review. So the usual sources that we usually suggest in a systematic review is what we call as a cozy strategy. So if you are doing you want to do a very quick systematic review, so you can actually concentrate on just the core sources. So which is the usual database, the PubMed, the Embase, Cochrane Central, bibliography of included studies. So those of you here who are doing systematic review as your group project, I would expect the minimum should be this. You should actually concentrate at the PubMed, Embase, Cochrane Central, bibliography of included studies. But it doesn't mean that if you want to go for more than this, if you want to go to an expanded strategy, for example, you want to go for the standard, so you can actually do it. Okay, so you can actually write to the expert, hand search key journals, other general database, and also perhaps a subject-specific database. So maybe there is an economic database out there, EconLit. Okay, maybe you are looking into a clinical database, a randomized control trial database. So you can actually expand your search strategy to include this. Ideal search strategy is that you include everything, including the grey literatures. Okay. Okay. So, but that again depends on your study questions. If you know your study questions, might not be able to get evidence that much from using just the core search strategy sources. So if you are still doing it, it means that, well, you are not doing a good job in your systematic review. So when you are doing a search strategy, one of the most important things that you also have to describe is the search terms and the keywords that you'll be using. Okay. So outlining and specifying what are the search terms is very critical so that then you can have a more focused search. For example, in this search in the literature that we are doing in this PubMed, let's say that if you are doing just a search for labor support, so just typing the labor support would return you 21,506 articles. Okay, so when you are searching, just typing labor support is what we call as a wild database search. Okay, so you use a when you are doing database, actually you can actually try to use the internal database tools to help you to refine your search return. So in database, you are actually allowed to use natural language, which actually close to what you have been doing just now, while database search. Just put anything that you feel you like. Or in database, they actually also have a controlled vocabulary. So inside that database, they actually have their own thesaurus that map one term to another. So using it actually would actually optimize your search strategies. And there is also another tools in the database, which is what we call as Boolean, which help you to actually expand or restrict your search. So in natural language, you use your own words, search words and phrases. So you can actually potentially search any field or database. So you use any term, but we have to remember that using natural language, you might be exposed, vulnerable to some of the language problem. For example, plural versus singular. If you search only child, what happens with children? Okay, so different spelling. So you have to know American spelling might return a different way from the UK spelling of aesthetic. Different terminology, pavement or sidewalk. Prefix, prenatal, pre, space, natal, pre, hyphen, natal. So those are actually language problem that is vulnerable with using just natural language in order to do your search. So if you are doing using a controlled vocabulary, you can actually be more focused. Okay. So for example, in when you are in a controlled vocabulary, you actually map one term to another. For example, Toyota, Rolls-Royce, Mini Ferrari are all actually mapped into automobiles. Okay, so the similar thing with a medical vocabulary as well. So you can have, for example, breast cancer, lung cancer, or stomach cancer, or oral cancer. All are actually being mapped into perhaps a solid organ cancer. Okay, so what happens is that these terms, this controlled vocabulary, actually allow you to make sure that you can have an hierarchical or conceptual relationship between these terms. Okay. But sometimes you have to be very careful with controlled vocabulary as well, because some of the new terms might not exist in the database. Okay. So which is why we usually use Boolean, okay, operator in order for us to actually expand and restrict our search. So Boolean, for example, the Boolean operator, or we can use or actually to combine the terms with the same concept. Okay, so in this review that we are doing now, actually we are looking into the effectiveness of doulas. Okay, so doulas is a kind of labor support. So it's not. So labor support is the general term. Okay, but doulas is actually it refers to the lay people who help mother to deliver their babies. So they are not healthcare professional. They are not healthcare professional. So what happened is that we know that labor support is the umbrella term that can describe everyone who is actually helping the labor process. So doula is just the subset of. It can actually be overlapping with this labor support. So what we're trying to do is that we want to make sure that our search expand as much as possible so that we can actually include all the studies that cover doulas and also labor support. Because maybe there are articles that they do not use the term doulas, they just use labor support. Okay? So we expand it using the OR Boolean operator. We want to know actually the effect of the doulas on the childbirth. Okay? But we also know that sometimes the process can also be termed as a continuous support. So what we want to do is that the process for childbirth as well, it can be a very wide body of literature out there. So we want to make sure that we're only looking into the studies that was published on childbirth, on continuous support during the childbirth, because we don't want also studies that we don't want to be including studies that looking into continuous support for maybe rehabilitative care or other disabled condition. So what we're trying to do is that we make sure that we use the Boolean operator and to combine the childbirth and continuous support together. We know that doulas is not midwife, so we want to exclude midwife from our terms, from our search. So what we do is that we use the Boolean operator not to make sure that we exclude midwife from our search. So combining all of these, we actually can use these informations to actually develop our search strategy. So in the population, we can actually expand childbirth or labor, and we combine it with N to only include doulas or lay support. And when we want to look into the attitudes, view, and opinions of using doulas for childbirth, we can actually combine it using the Boolean operators N. Okay. So with that, rather than have 20,000 plus evidence for us to see through, to read, in order to know, to make a conclusion in our system review, using this Boolean operator, we actually only have to read 118 articles. Okay. So in our methods, in our protocol, we also have to describe the eligibility, what will be our inclusion and exclusion criteria, who and how many reviewers will screen the articles for inclusions. So you need to have at least 2 independent reviewers to read the same articles. Okay. So because some of you here might know that even when you are reading a book, the second time you read the book, you usually have a different opinion on it, or maybe a different impression on how it should be. Okay, same thing as well. When you're reading the article, okay, sometimes when you read the article, maybe one reviewer say that, okay, this is a good article. Another one said, no, this is not. Okay, or maybe one reviewer say that, okay, this study should be included in our review. But another reviewer, when reading it, say, oh no, this is not relevant. Okay, so we want to make sure that the process is independent. Okay, not that we want to have any argument, but because we want to have an extra third-party opinion. Okay, so if you have this agreement, how actually we're going to solve it? So usually what we do is that we say that it's going to be by consensus. So if you have this agreement, you meet together, you discuss. If you still have this agreement, then you have to make sure that you go and see your field supervisor or maybe another third person to make sure that you can resolve this agreement. Will the articles be reviewed in blinded manner? Sometimes when you read an article, okay, when we say it's blinded, it means that you actually remove the author's name, the authors of the evidence name. Okay, so sometimes if you see maybe the study was written by Dr. Nuzalina, your dean, then you say, oh, this must be a good study. So you say that, okay. So you have bias in assigning that study a good quality score, and also perhaps in extracting more information from it than other studies. So blinding the studies actually allow you to make sure that you treat all the articles in your review in a similar manner. Another methods that you need to describe in your protocol is the data extractions. who and how many reviewers will extract the data. So these need to be specified, and also it has to be at least 2 independent reviewers. Extraction of data and quality assessment are usually done together. So development of a clear, well-designed data extractions and form and coding instruction manual is crucial, because if you just do it as you wish, everyone try to understand it or conclude it in their own way, you would find out that at the end of the day, you might not be able to get anything from it. So pilot testing is absolutely critical and necessary, okay, in order to make sure that the data extraction form is optimized, and also to make sure that you actually understand what you're trying to do in the first place. So reproducibility reduces error and subjectivity. It means that the methods that you are describing should be as explicit enough for you to actually to follow step by step without actually asking, hey, what is this? What the hell I should be doing next? You also have to contact authors for missing data to increase the accuracy of collected data. So sometimes, maybe when you are reading one article, okay, so you find that, okay, so they did not describe the how they select their samples in their study. So what you need to do is maybe you can actually write to the authors, okay, and some of these authors are helpful enough to say that actually, well, they admit the error that they did not describe it and inform you how actually they do it, okay. So the process of data extraction, okay, so once you outline all this protocol, so you have to do the data extraction. So because this extraction is prone to error, so which is why it has to be standardized and be done by 2 independent reviewers. Okay. So if only done by 1 person, maybe what we can have is that you can have it cross-checked by the second reviewer randomly. The disagreement between reviewers can be solved by consensus or a third reviewer. So, but if there is any such disagreement or you have to make a consensus, you need to make sure that you indicate it in your data collection form. And then you also ideally should also compute inter-rater reliability using kappa statistic to see whether the agreement that you have is actually good or not in your main outcome and also study quality data. So once data extraction is over, so you enter into your Excel. I think Excel is actually the better way, unless you actually know how to compile, create a database using Access. You can actually enter only the consensus data, compute and report inter-rater reliability, consider blinding, okay. And also if there are missing data, you can actually try to contact the authors to get more information out of it, okay. So in your protocol as well, you should describe what data should be extracted, okay. You should see that in the body of literatures, there are many ways actually how they can actually, how the researcher try to answer their study questions. For example, the questions of the effectiveness of paracetamol to treat fever, okay. So it can be reported in many ways by researchers. Maybe there is one study that reported in terms of the mean of temperature between group that receive paracetamol and group that receive placebo. Maybe in another study, what they did was they just do it in a binary form. Okay? Maybe what they have is that they only have it as the percentage of patients in group 1 who receive paracetamol that do not have the fever after 30 days. Okay? So it's just yes or no. Okay? So it means that you have to make sure that you know this kind of data exists in the body of literature, and you actually have to know how do you intend to extract it. Okay, so what happened is that usually what we have is that if you have such a problem, okay, so what we do is that you usually collect them all but you have to know what is relevant to it. Okay, and then you make sure that when you try to conclude, then okay. So what we do is that we extract first the information. Okay, but you make sure that you delegate them to their own category. For example, if this is reporting in OR or RR, you make sure that it is clearly specified in your data extraction form that this is OR and not the mean difference, okay, or mean or standard deviation. If you have continuous data, then you make sure that it is being recorded in your data extraction form as mean and standard deviation. Okay, so once you extract the data, again, this ideally should be done independently by 2 independent reviewers. So then you make sure that if there is a disagreement, this should be solved by again in similar manner that we have discussed earlier. And then you also have to describe whether you are going to compute any interrated reliability in order to make sure that we know that there is not much disagreement in the data extraction process. So the next thing that you need to outline in your protocol as well is how you actually assess the study quality included in your review. Okay, so you have to describe who and how many reviewers will assess study quality, what instrument or scale will be used for quality assessment, will a numeric quality score be measured, will quality assessment be done blinded, how will the reviewers resolve disagreement, will interrated reliability be measured, how will the quality data be used. So quality assessment, perhaps something that I need to discuss a bit more details here. So the reason why we have quality assessment of the evidence that you include in your review is that because the conclusion in a review, it can depend entirely on the quality of primary studies which make up the review. A meta-analysis of a poor quality studies cannot generate high quality summary results. And this is what Ian Chalmers says, okay, which I think reflect what quality assessment is about. Even elegant statistical manipulations, when performed on biased rubble, are incapable of generating unbiased precious stones. So quality assessment is actually a vital component of all systematic reviews. It sets apart a systematic review from a narrative review that do not distinguish or differentiate between a quality studies and poor studies. Many reviews which claim to be systematic review actually do not perform quality assessment, and this is actually means that that systematic review is a poor review. So what does quality mean? Quality means perhaps different things to different people, to different study design. In the context of systematic review, quality refers to methodological quality, the internal validity of primary studies. The internal validity means lack of bias. Okay, so I have been talking a lot about biases now, especially when I was trying to discuss the disadvantage of traditional review. Okay, and this is why the systematic review have their advantage over the traditional review, because we actually make sure that we take into account this bias when we try to appraise the evidence into our review. So there are 3 general types of bias in the internal validity. One is selection bias. How do you select patients into your study? Okay. So is it conveniently you just look into people who just whoever come across crossing your path, or you just do it randomly? Okay, which is the most ideal solutions? Okay. Information bias can also happen, and also confounding bias. So those 3 are the most important bias that can happen in a study. As you can see here, there are actually many types of bias as well that can affect internal validity of a study. Okay, so selection bias, again, I'm trying to rehash again what we were discussing earlier, but also trying to make sure that you can picture that bias in the process of generating primary evidence. Okay, so when you generate evidence, primary evidence, when you're doing a study, clinical trial, for example, you are recruiting the participants. Okay, so that is usually one of the first steps that you do in your clinical trials. Okay, so but when you're recruiting participants just conveniently, okay, there is a risk that you might be selecting only the people who are convenient to you, maybe only healthy people. Okay, so but ideally we want to make sure that we are not being biased, because if you are only selecting the healthy people, okay, so your result might not be reflective of the real clinical practice, which might consist of people who have more disease, who have more illness, who have poor mobility. So if you are not doing a random selection recruitment, then your study is actually at risk of selection bias. So once you have recruited the participants in a control study, usually then you would allocate that participants to either to receive an intervention or to be a control group. Okay, so how do you allocate it? If you do it just conveniently as well, so maybe you say that, okay, this girl is pretty, so then you want to give her a good the intervention. And this patient is ugly, so you say that, okay, it's useless for me to talk to her much, so you just give her the placebo, so that then you can rid of her very quickly. So it means that there is a risk of allocation bias. By right, it should be done in a random manner. So once you do the study as well, okay, so there is, by what you are doing as well, when you're trying to allocate it, okay, when you allocate it randomly, by right, the definitions of random is that everyone would have the same chance to be selected in another group. Okay, so when we say this, it means that by right, the other characteristics of the participant by right should be the same. Okay, so if you're not doing it in a random manner, okay, so maybe then you would have that the group who are in the intervention, for example, maybe they have more severe disease compared to the control group, or maybe you have the control group who have the more severe disease, whereas the intervention do not have the severe disease. So what you have is actually you have a confounding, which is the severity of the disease, and this actually is another type of bias in a study. So once you do the study as well, so some of the patients might drop out. They say, oh, I don't want to continue the study anymore. Some patients might stay until the end of the study. So the questions now is that when you do the analysis for the study, are you including all the patients, or are you excluding people who drop out from your study? Maybe people who drop out from the study, maybe because they cannot stand the adverse effect of the drug, which is why they drop out from the study. So excluding them from your study would actually expose your study to what we call as the intention to treat bias. Okay, so what you have to do is that in the analysis, by right, it should differentiate between people who are being excluded, who drop out from compared to the intention to treat statistical analysis that include everyone, every patient which begin the study until the end. Okay? So there is also a blending of outcome assessment, data collection method, statistical analysis that can actually contribute to the internal validity. So in order to assess the quality of study, okay, so you should be able to actually assess the quality of the study by actually critically reading the methodological part of the primary study. Okay, so what you can do once you've done that, okay, once you ascertain the study of the quality of the study, so then next maybe you can set the minimum quality standard for inclusion of study. What you can do maybe is that you would say that in the review, in the protocol, you say that in the review we will only include high quality studies. Low quality studies or poor quality study, we would exclude from our review. So what we can do with the quality as well, okay, we also can see if the difference in study quality can explain the heterogeneity or the variation in the study results. We can also use the quality of the study to actually weight the study results, where we can give a higher quality studies with higher weightage compared to the lower quality study. So it actually also allow us to allow the readers to interpret the strength of the evidence and also identify future research questions. So how do we actually assess the quality? So sometimes what we have now in a systematic review, we have tools or instruments to help the reviewer to assess the quality of the study. So we can use these tools to actually score the primary study. Okay, so each of the items in a scale will get a numeric score. So what we do is that we sum out the score, and then we can actually identify the quality of the study based on the total score. So this is examples of Jadat scale of a quality assessment tool. So this is Jadat scale, which is commonly used to ascertain the quality of randomized control study. So as you can see, in Jadat scale, there are only 3 questions. Was the study described as randomized? Was the study described as double-blind? Was there a description of withdrawal and dropouts? So if we give yes to any of the questions, the 3 questions there, it's 1 point. If it's no, then it's actually 0 point. So we give 1 additional point if the randomizations or blinding is appropriate, and we deduct point if it is not appropriate. So a good quality study should be above 3. The maximum score is 5. Okay. So though this is Jadat scale is for control trial. So there are studies which is using observational study design. So there you can actually use Newcastle Ottawa scale. So some of you here perhaps will be reviewing a cost analysis study. So by right you should be looking at the tools that actually appraise for cost analysis study. Okay. If you are appraising study for quality of life, for example, then you perhaps will be looking at the Newcastle Ottawa scale in order for you to understand the quality being to actually appraise the quality being used in that primary study. So how can you use the quality information? You can actually do a narrative discussion of impact of quality on results. Okay, maybe what you can say is that you say that okay, most of the poor quality studies conclude that paracetamol is more effective, but a higher quality studies would actually shows that there is no effect of paracetamol on reducing fever. So that's just examples. Okay. Another way that you can actually display or report this quality information is use a table. So you show the study A, what are their quality score, and what are the quality information that they are lacking. Okay. Or another one is you actually weight the data by the quality. Another way is to actually do subgroup analysis by quality, and another way is actually to include quality as a covariate in method regression. But this is we are not going to be covering in our discussion today. So this is the impact of quality on results, as you can see in our examples here. Okay. So this is a meta-analysis that shows the association between beta-carotene intake and cardiovascular mortality. So what we can see here, okay. So if you see this this graph here, okay. So it actually shows you that 2 groups. Okay, one is an observational study, cohorts study design, and the bottom one is actually trials, which is by right should be a better quality compared to observational study. So we can see that the observational study indicates considerable benefit between beta-carotene intake and cardiovascular mortality. So in effect, they would say that taking carrots or beta-carotene would actually reduce the risk of mortality from cardiovascular. But when you look into a higher quality study, control study, you see the opposite results. Okay, you see that actually taking carrots, taking beta carotene would actually increase the risk of cardiovascular mortality. Okay, so this actually tells you how quality can actually play an important role in giving you the conclusion for your systematic review. So another part of the protocol that you need to actually describe is how you're actually going to analyze your data. So there are software that you can use, but the learning curve perhaps is a bit tricky. RefMan, R, Stata is some of the types of the software that commonly used to do a systematic review or meta-analysis. You actually have to describe how you evaluate your heterogeneity. If a meta-analysis was done, what model will be used for combining data? If heterogeneity is found, what approach will be used to find reason for heterogeneity? So all of these from point number 3, 4 is actually belongs to meta-analysis, which you are not going to discuss in our lecture today. Okay. So will subgroup analysis be done? How will quality studies affect the analysis? How potential publication bias will be evaluated? So the results of your systematic review, you should describe your result at least in a table where you include the study participants in each study, the location, setting, intervention, comparison, outcome measures. You also need to include, at least in the appendix, the studies that you exclude and the reason why you exclude them. Maybe it's not maybe in your inclusion criteria initially was you're only going to include English publications. So once in the exclude study, so maybe you have the title of the studies that you exclude because they are non-English. So you also have to describe in the results sections the risk of bias in the studies and also the effects of intervention. So this is one example of the table commonly found in a systematic review. So this is what we call as a grade evidence profile. So it describes the quality assessment of the study. So when we say quality assessment, we actually describe the bias in the study. We also, in the table, the summary of the findings that we can find in each of the study. Okay. So once you've done these results, once you have presented the result, you have to discuss them, summarize the main findings and outstanding uncertainties. You have to actually describe whether the evidence that you found is complete or not. Okay, whether there is a clear directions that really that A is more effective than B, for example. Or maybe you will say that, okay, there is no clear direction, there is a mixed evidence out there. So you have to make sure that you actually make a general conclusions in your discussion. Okay. So you also have to describe what will be the potential bias in the review process. Maybe you will be saying that you do not have access to certain articles, and this actually can affect the review process. This can actually affect your review process, and this should actually be discussed in your systematic review. So you should actually conclude with how actually that review you had done would affect the practice, okay, and what should be done in the future studies in order to make sure that they can actually cover the gap of evidence that you have identified in your review. So systematic review, a characteristic of high quality systematic review is that it should have a clearly defined explicit questions. It should have a comprehensive systematic search for study. It should have an explicit reproducible strategy for screening and including studies. It should assess the quality of primary studies. It should have an explicit reproducible data extractions. It should have appropriate analysis and reporting of results. Your discussion should consider limitation and strength of evidence. Your interpretation should be supported by data, and the implication that you have should be well discussed in your review. Okay? So if you want to know more about systematic review, you can refer to this source. With that, I would end our discussion today on evidence synthesis. Thank you.